I want to welcome to the fifth and last lecture of the year for the City Center on Aging 23rd Annual Lefeber Winter Series on Aging. It's complicated, but this is what it is. So I'm your host. I'm Elena Volpi, and I direct the City Center on Aging. And by now, you should know already that this is a lecture series that honors the memory of Dr. Edward James Lefeber, a physician who started geriatric medicine on Galveston Island in 1939. He taught internal medicine at UTMB, and he took care of preferentially seniors. And later he became also the director of what is now the Meridian Retirement Community. And before he died, he saw UTMB developing the geriatric division, which has thrived ever since. So today I'm really delighted to introduce a friend and a collaborator, Dr. Ellen Binder. Dr. Binder is a professor of medicine in the Division of Geriatrics and Nutritional Science, and a professor of occupational therapy at Washington University, St. Louis. She received her undergraduate degree in psychology at the University of Michigan, Ann Arbor, and her MD degree at Washington University in St. Louis. Then she did her internship and residency in internal medicine at the Jewish Hospital in St. Louis, and her fellowship at Harvard Geriatric Education Program. And then she went back to the WashU in St. Louis to complete her training in epidemiology, and has remained there ever since as a faculty, climbing the entire academic ladder from instructor all the way to full professor. Dr. Binder is also currently a practicing physician at the Barnes Jewish Hospital in St. Louis. Her research focuses on rehabilitation of geriatric patients with a specific interest on improving recovery from hip fracture. She has been funded by the National Institute on Aging and other agencies for her research throughout the years, and currently leads a new major multi-site clinical trial, which has been recently funded with by a $50 million plus grant. Yes, to test if the combination of resistance exercise training and testosterone can accelerate recovery from hip fracture in older women. I'm really proud to be part of this study, and UTMB is one of the clinical sites of this study. So we will soon start recruiting for this study, and we'll recruit women who suffered a hip fracture and are undergoing rehabilitation. Dr. Binder has published more than 60 papers in high-impact journals and has received a number of awards and honors. So we're really, really happy and honored to have Dr. Binder today as a speaker of the Lefeber Winter Series on Aging. And the title of her talk is Recovery After Hip Fracture. How can we do better? Please join me to welcome Dr. Binder.
Thank you. I'm really very honored to be here today and honor the memory of Dr. Lefeber, who sounds like a true geriatrician and a wonderful clinician, and enjoyed meeting all of you that I talked to today. I really got a lot out of it, and I think some of you know it's going to inform what we do in our new project, so that's great. It's great to share ideas. You know, I started out as a clinical geriatrician for several years, and actually started out my career working in long-term care, which not a lot of people were doing in those days, and it really fueled my interests in geriatrics and in research. I was seeing a lot of older patients who were going through rehabilitation and sometimes felt frustrated by the limitations of what could be provided in a traditional rehabilitation setting. And so went back to the university and started to learn how to do research, and eventually, through my interest in exercise actually, funneled that into an interest in prevention in healthy populations, but also in trying to figure out how we can improve not just hip fracture recovery, but I think use it as a model for how to improve rehabilitation for all patients who have had injuries or deconditioning or other problems that have impaired their independence. Those are my disclosures. So hip fracture, as many of you are aware of, is an important problem all over the world and is becoming more of a problem. This is looking at the total number of fractures in the United States over time from 1990 to 2006, and the good news is that it was relatively stable at around 300,000. This is for men. The top is total, and this is for women, and men fortunately have a lower risk of hip fracture, but the total number of fractures was around 300,000. But then there was some slight decline briefly. There was some optimism that by preventing falls and maybe working on some preventive strategies that we might actually be making a dent in hip fracture incidence and maybe treatment of osteoporosis. But the prediction is that we're going to have increases in the incidence of hip fracture. This is looking at total numbers which are expected to rise in prevalence. Some of this is just a reflection of the fact that the total number of older adults is increasing. So the absolute numbers are increasing. But this is also from a paper that was modeling incidence and also projecting that, and this is now, but projecting from the past, and current statistics seem to be supporting it because the incidence has gone up. So we're going to see more numbers of hip fracture patients. All of you are probably aware that hip fracture patients often die after repair of the fracture. In-hospital mortality is a little less than 10% of patients, but within a year, somewhere between 25 and 30% of patients unfortunately die. Much of that happens within the first few months of the fracture because many of those patients are very sick to begin with or quickly develop complications. But the other interesting thing is that once you've had a hip fracture, you're still at higher risk for death over the next 10 years. And this is some data that shows for women and for men looking at excess mortality. Above is women, so 20% excess mortality, and this is by age. So the top line is women that are 90, the bottom line is women that are 70. So if you're a little younger, you know, at 5 years, it's an excess risk of maybe 8%. If you're 90, it's 30%. If you're a male, it's 30%. Interestingly, if you're a really old male, for some reason, it seems to go down. But for others, it never goes down to zero. There's an excess risk that goes on. So brings a lot of complications and health problems associated with it. The other thing that is probably more important at that stage of life is how people function in their life after they've had the hip fracture. And that's really what our interventions have been focused on. So a significant percentage of older adults who have had a hip fracture do not get all the way back to how they were doing before the fracture. This is percent of recovery months after the hip fracture, 12 months. This is just getting in and out of bed. Well, 70% of people are able to get in and out of the bed, but 30% still can't. You know, this is walking a block. 40% can get back to walking a block, but that means 60% can't. That's very high numbers. Now, some of those folks are in long-term care. So it's a more impaired population. But even for people that were completely independent before the fracture, this is looking at dependency in just walking 10 feet. And over time, after the dependency is really high, as you'd expect, and comes down, but it doesn't go down to zero. There's still a whole lot of people that require help. And this is referring to those who were unimpaired before the fracture. They were independent, who end up with an impairment 12 months later. So those that were independent and climbing stairs 12 months later, a high percentage can't walk 5 stairs anymore. So you can't walk 5 stairs. You may not be able to get back into your home if you were living in a home independently. It really can result in significant transitions in care. There are other consequences. It's not just about activities of daily living, but that's really important. People can't do the higher order activities of daily living. This is a population that often has cognitive deficits before the fracture, and half of them have increased cognitive problems in the hospital, but another 25% have new impairments 2 months later. Half may have depressive symptoms in the hospital, and a quarter persists 2 months later. They're going to be doing less socially and recreationally because of their impairments. And we actually found that 40% at 3 months after the fracture reporting moderate to severe pain in their hip that persisted. So continued impairments that need to be addressed and often do not get addressed. Patients' process of care is that they return to their orthopedic physician about 6 weeks to 8 weeks after the fracture repair. I hope there are not too many orthopedists here. But the orthopedist takes an x-ray and says, your hip is healing beautifully. And patients go, oh, great, that's great. But there isn't really a discussion about all the issues that I've talked about, and really that's not what the orthopedist is trained to do. You know, they've got an important skill in terms of repairing the bone, but hip fracture isn't just a bone disease nor a bone repair disease. It's much more than that. So there have been a lot of epidemiologic studies that have looked at, well, who's at higher risk for having these poor outcomes? Can we target those patients? And I've just listed the risk factors that have come up repeatedly in well-designed studies. I don't think any of them are big surprises. If the older you are, you know, the higher risk you are of having poor recovery, particularly over the age of 85. Those who are more impaired prior to the fracture, those with lots of medical problems or cognitive impairment. Social support turns out to be very important in terms of whether people get back to their home or not. The presence of depression, poor nutrition, how long it takes you to get up and walk after you've had the surgery. There's now been a lot of work to get people mobilized very quickly. The standard of care now is to get up and walk by 48 hours, unless there is an extremely severely comminuted fracture that just you can't bear weight on, and declines in muscle strength, which are often not even measured. The other thing is that this population is at a high risk for recurrent falls and recurrent injuries. So if this fracture didn't cause a major problem, you may have another one. So half of these individuals fall again within a year of the fracture. A third has more than one fall. A third sustain an injury, and 12% have another fracture. And again, the risk factors for that are very similar to those that predict whether you're going to have a fracture in the first place. Some studies have shown relationships with low vitamin D levels, number of medications, how makes sense how your balance is and what your physical activity have been. You may be in better shape if after the fracture, if you've already been exercising, what your vision is like. Many of these are well-known fall risk factors. But whether you fractured or not, nutrition seems to play a big role, very important. So this is a really challenging problem. This is a very elderly, often very frail population. And this kind of research in terms of developing interventions is very difficult to carry out. The patients, many of them are cognitively impaired versus non-impaired. Some are in nursing homes, not in nursing homes. We've got to be able to take care of everybody and target the interventions to what's most appropriate to where they are and what their needs are. The interventions that have been developed, some of them start in the hospital, some of them start 6 weeks later, some of them start 3 months later. So there's a lot of variation, and it gets difficult to compare one to another, or where it's done, whether it's done in the hospital versus the rehab center, how well everybody does the interventions and sticks to them. It turns out I'll get back to this, whether you're doing more than one intervention at a time can affect the success. And there's great interest in hip fracture all over the world. And so, for example, in Europe, until recently, and that's actually changing, hip fracture patients stayed in the hospital a lot longer, sometimes up to 10 days to 2 weeks, and often went immediately to really what was another section of the hospital, which was their rehab center, which might be in some cases more akin to what we consider to be acute rehab. In other cases might be more akin to a SNF. So a completely different approach. They're actually moving a little more to getting people out of these hospitals because they are facing the same budgetary constraints that we do. But many of the studies were done in this context, which makes applicability to what we have here in the United States difficult, and all kinds of different outcome measures. So again, hard to compare, but I'm going to try to, as best I can, provide a kind of a context for that. The kinds of interventions that have been evaluated include interdisciplinary team management. So having that nowadays, that doesn't seem like a big new concept, but this work started in the 80s, and in those days, having a physical therapist and an orthopedist work together in the hospital and plan and have team meetings was a big deal. So, and now the emphasis has been on co-management for longer periods of time, and in the United States and also around the world, people are looking at what's called a co-management model, where a geriatrician or sometimes a hospitalist physician will be the primary physician for that patient when they come in the hospital for the hip fracture. And the orthopedist is the consultant. Because of all these complications, it's the geriatrician that manages the polypharmacy and the cognitive impairment and the delirium and the physical, considering functional issues. And that model has not actually, it's just begun to really look at effectiveness, but the model's been put in place in many centers and is beginning to be evaluated. Similar to what's being done in a lot of post-acute care, a graduate nurse case management model to help improve outcomes, nutritional interventions, exercise interventions, multimodal, meaning more than one type of intervention at the same time, and really not much in the way of cognitive behavioral strategies. I list this as something that's been proposed and attempted, but to my knowledge there hasn't been any great work in this area, but I think it is important. Pharmacologic interventions have included anabolic agents. Those to stimulate appetite have been, I list this as potential. I'm not aware of anything other than what anabolic agents can do. And I am also not aware of work specifically with hip fracture patients related to antidepressants, but I think it's an important intervention to evaluate. So I wanted to talk a little bit about what nutrition and the nutrition interventions that have been attempted. And this is a very old study published many years ago that would be considered very basic data to most of those of you in here and that do metabolic studies and studies of protein turnover. But this was data collected on a surgical ward looking at urinary nitrogen balance and over postoperative 14 postoperative days. So it's demonstrating that very quickly, this is within 3 days, and you're all aware of it because you're doing these fantastic bed rest studies here. Within 3 days, these patients go into negative nitrogen balance. So their muscle breakdown starts quickly. They can start eating, and in this study, I don't know how this compares to your work, but it took 9 days for, on average, to get back to a net nitrogen balance. But you can see there's variation. There are a lot of patients who still aren't. And in this small study, they followed people out for 36 months. And it's incredible that for such a small study, they could demonstrate big differences in mortality. It's pretty striking. So this was the group that was depleted. And they also, the depleted individuals were people that were not the negative nitrogen balance, but they followed how much they were eating in the hospital and classified them as not well-nourished versus well-nourished. So those that were in their non-depleted group survived to a much greater extent, 90% versus 60%. I think that's pretty striking, and there actually hasn't, I mean, we know that there's an increased risk of mortality, but there isn't much newer data related to hip fracture. So this spurred a lot of work. Oh, this is the other thing. This is the only study I'm aware of that looked at the relationship between nutrition and function. So it isn't just about dying, it's also about how well you live. And this was a small study in Germany where they looked at how well people ate. They measured the percent that they ate on their plates while they were in the hospital, postoperatively, and classified them as less, 25% or less, I think 25 to 50, and greater than 75% of what they ate on their plate. This is their ADL, Barthel ADL. So this means they were all functioning pretty well. They were at 90%. They were almost completely independent, didn't get that much help, all of them, before. And then they looked 6 months later, and there was a significant difference in the people who, I mean, no surprise, but nobody else has really looked at these numbers. So a big difference in how people were functioning. People that are at 60 are dependent in some way in almost all their ADLs. So these folks are pretty dependent, and these folks are getting back to being independent. So pretty striking that how much, I'm sure there were other things going on to contribute to this, but again, showing that relationship. So I'm sorry for how small this is, and the small type is not really what's important. But this is from a meta-analysis that was one of the Cochrane database reviews that looked at what were 44 clinical randomized trials many of them were considered, I would say, moderate quality. There were issues with the design of many of them. And there were wide variations in the design of all of them. So some of them, and you know, the small numbers of patients. So, you know, no study had more than 73 patients. This up here is looking at oral supplements. And what they do in these studies is they pick an outcome of where there's data from all the studies that they can pool. And so for here, they looked at mortality, whether you got a supplement or not, and the risk of whether you would live or not, whether it made any difference. So from all the studies that used oral supplements, none of them, a few of them, actually it's, this is favoring the supplement. So a few of them had some effect, but they weren't, to really be effective, you need to those lines need to really all be over here. And they were, you know, small to modest effects, I guess is what you could say. There was a mixture from using nasogastric feedings, and a combination really didn't do much. And IV feedings made a difference, but these were probably very sick people that couldn't even take supplements. So I guess, you know, it's not great data. It means we need to do a lot better. This is just for mortality. This is looking at complications, and oral supplements seem to do a better job of preventing complications. The dots are further over this way. There's still some crossover. And the other modalities didn't seem to make a difference. There aren't really any good studies that look at longer term outcomes. And so the take-home message is that we really still don't know what nutritional intervention can improve outcomes for hip fracture. I think this center would be a great place to tackle that. And you know, you all have the data from sarcopenia that could be applied to this population, but not yet, because we have to do our other clinical trial. But it's just not well known. And as I mentioned, there's really a lot of limitations to the work that's been done with nutritional supplementation. It's just not adequate. They were really small samples. Often, actually one of the best controlled study was done in Australia, and they had trouble getting people to take the supplements. So even if you do the best to try to provide them, if people aren't going to drink them, it doesn't, you know, it isn't very helpful. And I think I've talked about the other issues. So, you know, my interest is in exercise/rehabilitation studies. Again, lots of variations in designs, and I'm going to show you, you know, some similar meta-analyses. But there's been more positive work, I guess, or outcomes related to exercise interventions, but a wide variation in the degree of the impact of the studies. So this probably doesn't project very well, and I apologize. This is from the study of exercise training that my colleagues and I did at Washington University now over 10 years ago, and is part of the basis of the study that we're going to start here at UTMB. At the time that we started this, there had been no work using progressive resistance training in hip fracture patients. The idea of putting a hip fracture patient on a weight machine was concerning to many clinicians, and we had to actually get, I was telling the students today, we had to get permission from orthopedic surgeons to do this because many were worried that it was going to impair fracture healing. So this was a 6-month study where at the first 3 months the patients did what would be considered physical therapy type or functional exercises that were done on mats or on a chair. stretching, balance, walking exercises. And the next 3 months were progressive resistance training. So 6 months, this is the control. This is what's called a physical performance score. This is the exercise group. So someone that has a score of 20, just to kind of put it in context for you, is someone that we would consider moderately frail. And some of the people, because that was the mean, there were people that were more frail too. So we were getting really quite frail individuals. And the individuals in the control group did a home stretching program, similar to what they would be prescribed by the physical therapist when they finish their regular course of physical therapy, either in the outpatient or the home setting. These individuals did the PT, the outpatient and progressive resistance training. And I think what we're really proud of is that this number of 30, the top of the scale is 36. 30 is considered pre-frail to non-frail. So we took individuals who were frail and got them on average to being independent and non-frail. This was a self-reported measure called the Functional Status Questionnaire, and the findings are pretty much the same. Same, actually, scale ranges. So when 36 means you have no difficulty doing activities, and they got up to 28, which means that they had a little difficulty with a few activities. So that was our study, and what I'm showing you here is the pooled outcomes from a meta-analysis done a couple of years ago, looking at the outcome of mobility. And they had to get measures of mobility, and these are all exercise studies that were randomized controlled trials in cognitively intact individuals done all over the globe. They did vary in the length of the duration of the studies. Most of them were around 6 months, but there were a few that were shorter. And some included progressive resistance training, some did not. Do you want to guess which ones did? So they are the ones that showed the greatest effects on mobility. So ours is at the top. Another one by Dr. Hauer, I think in Germany, and Cilius was the third. But these are the studies. I mean, most of these showed some effect on mobility, that exercise did good things for mobility. But the study really showed that those that included progressive resistance training seemed to have the most meaningful gains on mobility. This is another very similar analysis that included a few different studies, and I pulled this just because it provided information about activities of daily living. I mean, these, you can look at things like gait speed and, balance and all these measures that are secondary measures. But what we really want to know is, can you change people's function? So we showed we could change their mobility. And again, there's some positive effects in those that had progressive training on ADL function. Not as big. It's harder. Part of the reason for that is that the people who are coming in for these kinds of interventions tend to be more independent to begin with because they're coming into your center and they can do that, and so getting those gains is a little bit smaller. But nonetheless, they do show improvements. This is also hard to see, and I apologize. This is a study by Dr. Latham at Boston University that was published in JAMA a couple of years ago and got a lot of press. They did a 6-month home-based exercise program that used more functional type of exercises. And it was published as a positive study, and you can't read this, and I'm sorry, but I'll tell you, and I hope just my showing it will be helpful, but this was the SPPB, the Short Physical Performance Battery, which is a measure of mobility. This was their AMPAC mobility score, and this was their another activity score, so telling whether people were more active or not. This is when they started. This was at 6 months, and they actually followed people out a few months later to see if the intervention effects persisted. So yes, those in the exercise group did get better than those in the control group on their performance score. But I will tell you that the score that they got to is analogous to the score of the control participants in our trial. So they saw a statistically significant improvement, but it isn't as great an impact on mobility. And this was a really good study and really well designed, and I'm not, important work. I think, promoting my bias that it takes more than just functional exercises to really improve function. But that's my perspective from this. And this was an amazing study by Maria Friadaroni Singh, where she, in Australia, was able to do 12 months of progressive resistance training, combined with multidisciplinary assessment, where they did targeted interventions related to problems such as nutrition, depression, polypharmacy. So they were really able to do it in the ideal way and saw an 81% reduction in mortality, a reduction in nursing home admissions, and improvements in functional measures. So I guess, maybe that's as good as it gets in a way. It was a very powerful study, but 12 months is a long time for these interventions, and that's the challenge for all of us. So as I mentioned, thus far, I think the data related to exercise after hip fracture suggests that successful interventions include progressive resistance training. Those that have been most successful have included cognitively intact or mildly impaired individuals. It doesn't mean that you cannot have success with those with dementia. It just means that the studies haven't been done well enough yet. I think that's another area that we need to look at, and that it probably requires particular targeting of the intervention, and that attention to nutrition and a multi-component approach is probably important. So moving on to potential pharmacologic interventions. I showed you the data from nutrition about how quickly hip fracture patients go into negative nitrogen balance. And this is data from the Baltimore Hip Study. Dr. Magaziner, I think, was here a few years ago and spoke. And they did a large epidemiologic study. There's also done some intervention studies, but they did DEXA scans for up to a year. They did it in hospital, 2 months later, 6 months later, and 12 months later. And this is demonstrating the percent change in lean mass and fat mass in the year after the hip fracture. And the important take-home point is that by 2 months, overall, the hip fracture patients had lost 6% of their lean mass, which persisted. It didn't come back. So there's a persistent loss in the amount of lean tissue, muscle, in this population. The question is whether interventions to increase lean mass, and that's probably another lecture in itself, will translate into improvements in muscle function and muscle strength. But that is where pharmacologic interventions may have an impact, and something that we want to look at in our new study. Whoops. So these are some of the potential anabolic agents that have either been studied or proposed. There's only been a couple of studies of growth hormone, one of which has demonstrated some positive effects on muscle mass and on strength. To my knowledge, not functional improvements. Teeny studies of testosterone and nandrolone. There's been discussion of looking at androgen receptor modulators, which are essentially testosterone that is specific to muscle. And I think there's some studies that have been proposed, but none that have been completed in this population. Myostatin antagonist is an investigational compound which is a negative regulator of muscle growth, and so when you inhibit its work, it can induce skeletal muscle growth and hypertrophy. So there's been work with these drugs in patients with healthy patients in sarcopenia. There's one study of hip fracture that's ongoing now, and maybe we'll know more about that soon. The studies in non-hip fracture patients have shown very modest improvements in strength and in, I would say, small to modest improvements in function. So our study is going to be done in women. So, why would we, there's a lot of concern, why would we think that women might need testosterone, or why would that help them, or do they have testosterone deficiency like men do? And we probably don't understand enough about that. This is data, cross-sectional data, looking at over the lifespan, and so these numbers are just age group from age 20 to age 80 of serum levels of total testosterone, free testosterone, androstenedione, DHEA. And there appears to be a slow and gradual decline over the lifespan, which there's in many women, a more abrupt change after menopause because some testosterone is made in the ovaries. In testosterone, not all women get to what we would consider to be deficiency levels, but many do. And it may be, there's some preliminary data that suggests that frail female hip fracture patients may have lower level than healthy elderly hip fracture patients, so they may be a higher risk patient population. So we did a pilot study, which is part of the basis of the study that we'll be conducting here and at other centers in frail female hip fracture patients, where we gave them testosterone replacement without exercise because it was a pilot study and we had limited funds, to look at the effects of just testosterone replacement on muscle and function. They were on average 80 years old and started similarly very frail with their physical performance score. I told you around 20 is pretty frail, and this group is 16. And we were able to demonstrate this is their fat-free mass on their DEXA. So the placebo women's lost lean mass, and the testosterone group gained lean mass, which was statistically and possibly clinically significant. There was a non-significant but a trend toward increasing the area of their thigh muscles, so maybe their thigh muscles were getting bigger, and similarly a trend toward increase in their knee extensor strength. So no, this was very small. This was only 15 people, but it was a signal that maybe replacing testosterone in these elderly female hip fracture patients who also had clinically low levels of testosterone might get increases in the size and the strength of their muscles. And amazingly, this was part of the basis of the study that we are planning to do. So we are asking the question about whether testosterone therapy in elderly female hip fracture patients can enhance the effects of exercise training to improve recovery. We called it the Step High study, or starting a testosterone and exercise program after hip injury. And our goals are to evaluate in frail female hip fracture patients whether 6 months of testosterone therapy combined with the exercise training program that I described to you will improve mobility, muscle strength, activities of daily living, whether we see the changes in lean mass and bone that we think mediate that, and also whether their quality of life improves. We're going to recruit 300 women from 6 clinical sites, including UTMB. We will be recruiting women only, over 65 years and older, who have had a hip fracture within the previous 3 months. We are targeting women that were community dwelling prior to the fracture. So this is really trying to say, can we help people that were independent before the fracture stay independent? There's going to be 3 study arms. Our control group is what could be considered enhanced usual care. They will receive a home exercise program that is prescribed by a physical therapist, similar to what is prescribed at the end of standard physical therapy. But they'll come in once a month and meet with the trainer to go over the exercises and get a little more attention, and they'll get a health education program monthly. And so we hope that that will help to improve their health without doing the formal exercise training. And the other groups will perform the exercise training program that I described, although we're actually going to do the progressive resistance training for a little longer than 3 months. Our goal is to get it going by 2 months into the intervention. And one group will also receive topical testosterone gel. And our goal is to get their serum testosterone levels actually a little bit above what would be considered the normal range. Because it's still much, much, much lower than where male levels are. And we think that that's probably what it's going to take to have a significant impact on their strength and their function. Our primary outcome measure is how far people can walk in 6 minutes. It's called the 6-minute walk distance, and it's a measure of mobility. And just for those of you who may be recruiting or know people that have a hip fracture, we are really trying hard to customize this to the needs of the population. So we know this is a population of people who do not drive, and we will be providing transportation to all of their visits and assisting in any way we can be helpful with the logistics for that. So to summarize, I hope you understand that this is a high-risk population for poor recovery due to many factors. It is never just one thing. Nutrition, although I think is extremely important, to date really haven't demonstrated any significant long-term effects, but we need more studies. Extended rehabilitation and exercise seems to be the most potent stimulant for muscle strengthening and improvements in performance, and has shown benefits at a year after the fracture. And we also don't know enough about any pharmacologic strategies that might be helpful. I think that it will take a multidisciplinary and multi-component approach. We need to understand all the effectiveness of the components and probably eventually put it together and customize it to different locations of care, different patient populations, Many of the interventions that I'm describing aren't yet ready to go into the clinic, and the next step after we demonstrate their benefit will be to figure out how are we really going to get this into the real world of clinical care, and what's the cost effectiveness, and how can we make this cost effective. So I am happy to answer questions, and hopefully left plenty of time for that. Thank you very much for your attention.
Questions, yes. I couldn't read your interventions, but were any of them for DHEA orally and NAD plus?
No.
And are there any studies considered in that direction?
Not in hip fracture, and I not that I'm aware of. Not that I'm aware of. I don't. My take is I don't think that the evidence suggests that we should push it at this point. So, yeah.
I was wondering about your androgen gel. Is it something that's on the market, or?
Yes, it's commercially available on the market. Yeah, so that's not an issue. It's not inexpensive. Yeah, but and the other thing to emphasize is this is not an intervention this is a short-term intervention. This is not something that we are promoting that you go on for the rest of your life. This is really looking at, will this boost the effects of exercise? And we also hope to also look at how long that effect is sustained. Yeah.
My name is Donald Lefeber. I'm a researcher and acupuncturist with the pain recovery program at the Mortality in Houston. And we have a pretty integrated program with the pain recovery with different patients, especially some substance abuse or opioid addiction. And anyways, I wanted to hear about what you think maybe some of the biological mechanisms behind using the resistance training, and maybe what kind of roles you see for future research with alternative medicines like acupuncture, mind body therapies. And some of these we utilize in our program there for the recovery of lots of severe pain patients.
Lots of questions in your question. So I think exercise has a number of mechanisms. It has, we're focused on mechanisms related to what's going on in the muscle, but we all know that it has a lot of effects on the brain. So, it can be transformative in terms of effects on mood and cognition and even pain. So there are many ways that it could mediate recovery, which we will not be, and we haven't even measured them all. So, yeah, there's a lot going on, and we can only focus on part of it. But I think it's why exercise can be so powerful of an intervention in those that can, follow through and do it. Once you're motivated, and there are people that can, in this population, we are often working with people who did not exercise before they had their hip fracture. So this is, in fact, it's only a small portion that might be regular exercisers before. What was the second? You had a second part of your question.
The role in future research, utilizing alternative medicine.
Yeah, I think that we need to really understand a lot more how that can help recovery from a hip fracture. So I talked about pain. I talked about how there's a high prevalence of persistent pain. We do not do a great job with addressing that. We know we've got an opioid epidemic in our country, and we don't know enough about the elderly in that, But there are many patients that unfortunately the only intervention ends up being a pain medication, and so there may be other potential interventions that could be helpful. So go research it.
Spread the word.
Any more questions from the audience? If not, then thank you very much
Okay.
for the very nice talk.
UTMB Health, working together to work wonders.